For our final lecture, we're going to talk about patients with biliary disorders. So these are going to be patients with problems with their gallbladder, their common bile duct, and their bile ducts. Here are your learning objectives for this lecture. So we're going to start with a little bit of understanding of the anatomy and physiology of the biliary system. So the biliary system or biliary tract is a network of ducts, organs, and accessory structures that work with the liver and the duodenum in aiding digestion and absorption of fat. So this will include the gallbladder, which stores and concentrates the bile ducts, which helps to transport bile, and the sphincter of Oddi. This helps control the bile into the duodenum. So first we're going to talk about our the gallbladder. This is that green pear-shaped muscular sac that's located beneath the right lobe of the liver. This usually can hold about 50 mLs of bile, and so its main functions are to store that bile between meals and secrete that bile when foods are eaten, especially greasy, high-fat foods. We then have our common bile duct. This is formed by the formation or the union of the cystic duct and the common hepatic duct. And this is the area that carries bile towards that duodenum. So our gallbladder helps to secrete bile from the gallbladder into the stomach to help break down fatty foods. Then we have our sphincter of Oddi. This is a muscular valve located at the junction of the common bile duct and the pancreatic duct and enters in at the duodenum. This helps to control the flow of that bile and pancreatic juices into the small intestine, but oftentimes we can have closure or obstruction of that sphincter, and this is what can cause problems with our gallbladder. Okay, so we're going to talk about some common disorders of the gallbladder. Our first one we're going to talk about is cholelithiasis. This is essentially gallstones. So gallstones are formed within the gallbladder and are a solidified component of bile, which is made up of calcium salts, bilirubin, and cholesterol. So when those buildup of those stones occur, sometimes those stones can obstruct the common bile duct and lead to inflammation and necrosis of the gallbladder. Our patients can also get cholecystitis, which is inflammation of the gallbladder. Oftentimes, this is due to those obstructions of those gallstones and can also occur without gallstones present in patients that are super critically ill and have impact from the pancreas and liver as well. We then have choledochrolithiasis. This is a common bile duct stone. So this is a presence of a gallstone found in the common bile duct, and this helps or prevents blood flow or bile flow, from the bile duct into the duodenum. Then we have, oh boy, this is a tough one, aculocystosis cholecystitis. So this is an inflammation of the gallbladder without stones. This is what you'll see in those critically ill patients or patients who have had an operative treatment. So we have many risk factors for disorders relating to the gallbladder. For most of our risk factors, we have patients who are obese or have a high fat diet, patients who don't eat enough fiber, they're increasing their fat diet. The 4 F's, so patients who are female, who are 40, they are still fertile and they are fat or obese. Patients with a history of gallstones, or patients who have had prolonged fasting or TPN use. So these are all patients at risk for gallbladder disease, but your most common patients that you're going to see a gallbladder attack or gallbladder disease is in your 4 F's and your obese patients who eat high fat diets. Okay, so we're going to talk about this cholecystitis or inflammation of the gallbladder. Cholelithiasis is that buildup of those stones, so that formalized gallstone formation. With our gallstone formation, oftentimes what we're going to see in our patients are going to be right upper quadrant pain. Usually the pain radiates to the right shoulder or their back, especially after fatty meals. They're going to have nausea, vomiting, belching, jaundice, especially if that bile duct is blocked, and they may have ischemia of those organs as well. We're going to talk more about clinical manifestations and signs and symptoms on the next page, and we're going to talk a little bit about nursing interventions and like diagnostic tools as well. So again, your clinical manifestations are going to be that right upper quadrant pain, especially pain that radiates to the right shoulder and the back, kind of a sharp pain. They're going to have nausea, vomiting, bloating, and belching. They're going to have what's called a positive Murphy sign. So this is where a practitioner or provider will place their hand up under the rib cage and press down. Those patients will have pain with inspiration. So while they're pressing down, the patient's going to take a breath in and they'll have pain. They may also have jaundice, so darkening of the yellowing of the skin, darkening of that urine, and clay colored stools as well. So those are going to be most of your clinical manifestations or cues. Typically, we will diagnose this with ultrasound. This is usually the most common and non-invasive. So they'll be looking for stone buildup in the gallbladder and looking to see if there is an enlargement of that gallbladder as well. They may do what's called a HIDA scan. This looks at the bile flow and looks for any gallbladder dysfunction. They might use an ERCP, so this is used to locate and remove stones, and we'll talk a little bit about this in our surgical management slide as well. They may also use CT or MRIs, which can look at perforations or biliary dilation and help to detect if there's an enlargement in that gallbladder as well. Then we look at our lab results for our gallbladder. So oftentimes we're going to have an elevation of liver enzymes or pancreas enzymes, especially if those organs are also involved with the backup or backflow of bile. They may also have an elevated WBCs, which is a sign of infection due to that blockage of that gallbladder and necrosis of the tissue, and they may also have an increase in bilirubin. For your medical management, we're going to make sure that we focus on a couple different things. So first thing we want to focus on is pain management. So a gallbladder attack can hurt the patients. They have pretty severe pain, especially in that right shoulder and into the back. So they will be given pain medications, usually with an NSAID or an opioid. Then we want to make sure we hydrate. We want to keep them NPO to decrease gastric secretions and gallbladder secretions. So keep them NPO, but place them on some IV fluids to make sure we increase hydration. If infection of the gallbladder is suspected, we're going to do antibiotics and get that on board, and probably do a prophylactic antibiotic prior to surgery. We would anticipate removal of the gallbladder, removal of the stones, depending on how severe that is. So we would anticipate getting them ready for surgery. If the acute cholecystitis resolves itself and those gallstones are able to pass, then we would reintroduce them to a diet, focusing on educating on a low-fat diet itself. But initial phases, we keep NPO. After that, we can feed them a low-fat diet once those symptoms resolve and that attack of the gallbladder decreases. Okay, so we're going to talk about the surgical interventions that we can possibly do to remove the gallbladder. So there's two different kinds. The gold standard and what you'll primarily see nowadays is called a laparoscopic cholecystectomy or lap chole. This is done laparoscopically, so that's the image on the left. This is minimally invasive and it has a shorter recovery time and fewer complications for patients. This is especially good for patients that come in with the gallbladder problems and we catch it early, or we can kind of get that gallbladder out easily. The right side is an open laparoscopic or an open cholecystectomy. So that's where they will actually do a full surgical incision. They can visualize that gallbladder and they can remove that as well. This is used for patients who have severe inflammation. Maybe they caught the gallbladder infection late, or they have adhesions, which would cause that laparoscopic procedure not to be um, as beneficial. We also can do an ERCP, and I believe I explained that in the pancreatic lecture as well. But that's where they'll go in with a camera and remove the stones itself and can help with that bile duct decompression. So usually they'll start with an ERCP if they can get the stones easily, but oftentimes you'll see a lap chole done just because, we can do without our gallbladder once we find that it's causing too many problems. So many people get gallbladder surgery as well. Now with this surgery, we want to do our pre-op stuff. So we want to make sure we educate the patient. They're going to be under general anesthesia. They're going to be given what's called carbon dioxide gas, and that's introduced into the abdominal cavity so that that abdominal cavity can be kind of expanded so that the provider is able to see and visualize those organs. So that's one thing you want to educate on because it causes a lot of gas pain after surgery. And so we want to educate them on that that's to be expected, that high level of pain is due to that CO2 buildup. We want to make sure that we educate them on activity levels post-op, and we want to make sure that we educate them on dietary needs and things like that and potential risks. So for our intraoperative, the patient's just going to have that laparoscopically done. So typically they'll do about 4 or 5 small incisions. They're about maybe a quarter of an inch to a half inch wide. And those little cameras are stuck in underneath the skin and are able to remove that gallbladder. If it's a full open coli, then we would obviously have a higher risk for infection, a higher risk for post-op complications. So we would educate on that. With our post-op recovery for our procedure, we want to make sure that we monitor for bleeding and bile leaking. So we want to make sure we notify the provider for any fevers or jaundice or right upper quadrant pain. Obviously want to monitor for bleeding. That's with any surgery out there, but we're monitoring for signs and symptoms of hypovolemia, bleeding into the abdominal cavity, bruising anywhere on the abdomen or on the back, or distension of the abdomen. We want to make sure we monitor for infection for about it's about 3 to 4 days after the procedure. We'll want to monitor those sites where they've inserted that laparoscopic camera for infection. Now, usually those patients post-op, they do have little steri strips, like little band-aids on their stomach in those sites. Those are going to fall off on their own. So the patient should not rip those off or tear them off. They'll fall off on their own. Patients should be educated on early ambulation and position changes. This is especially important for reducing pneumonia, but it's also related to that CO2 gas retention in their abdomen and abdominal cavity. So those patients are going to complain of feeling distended, feeling gassy, and having sharp pain up in their shoulder blade area on the right side. That's because those CO2 bubbles tend to rise up and cause pain in their shoulders. So patients should be encouraged to ambulate frequently. They might use a gas medication like simethicone, but for the most part, getting up and walking or rocking back and forth in a rocking chair will help move those CO2 bubbles out of the way and help them kind of dissipate in the body. We want to make sure we get them up walking early, right? Especially if we have an open coli, because we want to prevent pneumonia and prevent DVTs as well. For your post-operative nursing care and teaching, we want to make sure that they're NPO until they're fully awake, able to talk, able to follow commands, and their gag reflex is good. And then we can advance that diet from clear liquids to low fat diet, because remember, our end goal is for them to start eating a low fat diet. If they've had their gallbladder removed, they now can't really process high fat foods as well. So we want to make sure that they do a low fat diet. Want to make sure that they get good pain management. So, analgesics as needed, making sure they get up and walk. They have heat packs to their shoulder for gas pain. They get up and walk to get rid of that CO2 gas. Those incisions should be kept dry and clean. They can shower after about 24 hours. They should not do any baths, hot tubs, swimming pools, lakes. They shouldn't scrub it with any soaps. They should just kind of do a mild cleanser and keep that skin clean and dry, monitoring for signs of infection. For activity, they want to avoid lifting anything that's heavier than 10 pounds for about 1 to 2 weeks because they did just have surgery. So we want to make sure those incisions and everything stay closed and they don't have any complications. They want to avoid fried and fatty foods for several weeks and make sure that they really do a low fat meal and gradually resume to a normal diet, but try to avoid high fat meals in the future. They definitely want to avoid any alcohols, nicotines, or narcotics, as this can, hinder their surgical recovery as well. Oops, I put this on this slide and talked about it on the previous slide. So just listen to the previous slide and take notes on this slide. Same thing here. This belongs with the information on slide 10. So just take notes here. Okay, so some potential complications from issues with our gallbladder would be things like a bile duct obstruction, bleeding after that surgery, wound infection after that surgery. We may get pancreatitis from gallstones that may migrate to the pancreas. So remember pancreatitis and the things we talked about in our previous lectures. We may get an abscess from our necrotic or infected gallbladder if it's not removed early enough. So we may have to monitor for signs and symptoms of infection, sepsis, give antibiotics. This could lead to what's called peritonitis. This is an inflammation and infection of that peritoneal or abdominal lining of the stomach, and that can lead to sepsis as well. So we really want to catch this stuff early, treat it, remove the gallbladder, remove those stones, and get these patients healthy and on their way. Okay, so now we're going to talk about pancreatitis. So pancreatitis is an inflammation of the pancreas. This results from premature activation of those pancreatic digestive enzymes. So what occurs is that the pancreas will start to secrete pancreatic enzymes, and this leads to a breakdown of the pancreatic tissue so that the enzymes actually cause destruction or autodigestion of that pancreatic tissue. There are two different types of pancreatitis. There are acute pancreatitis, which is sudden, but it's reversible, or there is chronic pancreatitis. This is usually progressive over time and is irreversible. So when we hear pancreatitis, we basically think about the pancreas starting to digest itself. So those pancreatic cells are eaten away or eroded away by the pancreatic enzymes. So our normal pancreas has two different functions. There is the exocrine pancreatic function, which is where our pancreas secretes those digestive enzymes. Those pancreatic enzymes are amylase and lipase and trypsin. So those are the three to really note for our pancreas. And these are going to look at lab levels as well. So be familiar with those. They secrete that digestive enzyme to help aid in digestion. Then we also have that endocrine process. This is where the pancreas releases insulin and glucagon and helps with glucose regulation. And we talked about this in our endocrine lecture. In pancreatitis, that enzyme is activated inside of the pancreas instead of being secreted out. So those enzymes start to destroy that tissue, which leads to that inflammatory process, which leads to bleeding and leads to necrosis of the tissues. So we want to make sure that we are aware of pancreatitis and what it can cause to the patient. Now, there are certain causes or risk factors. So gallstones, which we talked about a few slides before, they can actually obstruct the bile and pancreatic ducts. So this is most common in women. We'll have gallstones and it can lead to a blocking of the pancreatic duct as well. We also can have problems with alcohol use. So this directly is toxic to those pancreatic cells. They can have trauma or related to surgery. So any abdominal injury or trauma like car accidents can lead to a destruction of the pancreatic cells and a release of the enzymes. Or after ERCP. So let's say the patient goes in for surgery, they go have an ERCP, a removal of gallstones. this can actually trigger a release of the enzymes or a leak of the enzymes of that pancreas as well and can cause pancreatitis. Medications and infections, things like viral hepatitis, mumps, use of thiazide diuretics, NSAIDs, corticosteroids, these all can cause the pancreas to become inflamed and have issues with pancreatitis as well. So for your clinical manifestations with acute pancreatitis, this is going to be short-lived and sudden. They're going to have severe epigastric pain or left upper quadrant pain. Now, this usually will radiate to the back or left shoulder. So sometimes patients can think they're kind of having chest pain or a heart attack, but they're found that they're having pancreatitis as well. Most of the time, pain is worse when the patient lays flat, and it's oftentimes relieved when the patient kind of leans forward or lays in a fetal position. This helps to put pressure on that pancreas and helps with splinting. They will have vomiting, nausea, may have some decreased or absent bowel sounds. They might have abdominal distension. They're probably going to have a low-grade fever, and they may have some signs of bruising. Now, the two signs of bruising they're going to have is called Cullen's sign. This is where they will have periumbilical bruising, so that's bruising across the abdominal area around where the belly button is, or they may have gray Turner sign. This is flank bruising, so that's bruising back in the back where the kidneys kind of are hidden. They may also have jaundice if that biliary obstruction is present as well. So for the pancreatitis description, most patients will complain of pain that radiates to the back and around the abdomen, almost like they're wearing a really tight belt. For your diagnostic findings, your patients, we're going to get some lab levels. So we're going to look at the amylase level, the lipase level, and bilirubin levels. So we're looking to see if there is a pancreatic leak, and so we'll see that in elevated amylase levels, or pancreatic destruction of those cells, which we'll see in an elevated lipase level. We may also do a CT or an abdomen or a abdominal CT or an ultrasound to look at pancreatic edema or to see if there's any necrosis of that pancreas. And this usually will confirm that diagnosis from the bilirubin and amylase and lipase levels. For our patients, it depends on whether they're in acute pancreatitis or chronic pancreatitis. So for our patients with acute pancreatitis, first thing we want to do is rest that pancreas. So we want to give NPO, so nothing to eat or drink to help suppress that pancreatic secretion. We want to put them on some IV fluids to help prevent hypovolemia and give them pain medications. Usually IV medications like morphine or hydromorphone for pain is optimal. So we don't have any PO medications, any PO eating or drinking. We then want to make sure we're looking at fluid and electrolyte balances, making sure we replace any of that and prevent complications, okay? For our patients with an acute pancreatitis, once that resolves itself, those medications work, we're decreasing that pancreatic problems, then we can increase their diet, starting at a clear liquid diet and then advancing to a low-fat, high-carbohydrate diet when tolerated. For prolonged NPO patients, they may need enteral feeding, but for the most part, acute pancreatitis resolves itself. We may give medications, so things like antiemetics like Zofran or an H2 blocker or PPI like ondansetron or ranitidine. These are given to help decrease the secretion of those acids and those enzymes. We then also will give antibiotics, especially if that pancreas has been necrosing or is kind of infected. So we may give antibiotics as well. So again, nursing priorities for acute pancreatitis, we want an NPO. They may get an NG tube to also help with decompression and a removal of those secretions. They're going to give IV fluids, IV pain medications, and monitor those lab levels, amylase, lipase, and bilirubin levels. For your chronic pancreatitis patients, this usually is progressive and it is irreversible. So this does lead to a permanent damage of the pancreas. So these patients may have problems with insulin production now because of that endocrine function is lost, but they may also have problems with secretion of those pancreatic enzymes. So for our patients, we want to make sure that we educate or look for the cues. We want to look for chronic epigastric or back pain, weight loss, malnutrition, problems with hyperglycemia or signs of diabetes, jaundice if that bile duct is involved, and statorrhea, which may be those foul smelling fatty poops. CT MRI usually will diagnose this along with amylase and lipase levels, and may usually show that it is, a completely irreversible fibritic or scar tissued up pancreas. We do worry for our patients with pancreatitis. We do worry that they do have an infection, and that pancreas becomes so necrosed that infection can travel through the bloodstream and they may become septic. So we want to watch for signs and symptoms of infection, monitoring for fevers, watching white blood cell counts, and really just making sure that they're not getting worse. So we're watching for worsening of symptoms. Also make sure that for your chronic patients, those patients will no longer have pancreatic enzymes that are secreted because that pancreas is not working. So those patients will need to have pancreatic enzyme replacement therapy. So these are medications we give. That medication is called pancreolipase or Creon. I have that there in the picture. These oftentimes are given in capsule form. They're like a little capsule with some powdery enzymes in it. These can be swallowed whole. Usually they need to take that with meals. So every time they eat something, they take their pancreatic enzymes that help to break down that food. You can open the capsules if needed for patients that can't really swallow easily and sprinkle it on some applesauce or something. But just remember, those are pancreatic enzymes, so they're very caustic to tissues. So make sure they rinse their mouth out and they wipe their mouth off, and you watch for any stomatitis or ulceration of the mouth if you're doing it that way. Other medications that we give would be pantoprazole. So this helps with preventing stomach acid. So you'll see a lot of patients, not stomach acid, it does help with stomach acid as well, but it also helps with gallbladder secretion and pancreatic secretions as well. So it kind of decreases secretions of that entire GI system. That's why you're going to see pantoprazole given to most of your patients in the hospital, because high levels of stress causes our GI tract to kind of secrete all these enzymes and overactive metabolism. And so we want to decrease those secretions and the caustic effects of those as well. So just keep in mind the difference between acute pancreatitis, chronic pancreatitis. For acute pancreatitis, we really want to make sure we NPO them, maybe get an NG tube, decrease those secretions, and try to get that healed up. For chronic pancreatitis patients, low fat diet, watch for signs and symptoms of worsening inflammation, but we would have to replace those pancreatic enzymes for them. So this should be really all you need for pancreatitis, but we'll kind of talk about it in our little meeting today as well.